that is the thrombotic stroke, the embolic stroke, and the hemorrhagic stroke from your history itself. This is very important point that say suppose if you are writing the history of thrombotic stroke or your patient is a case of thrombotic stroke, you have mentioned the progression, the early morning onset. Then you have to also mention in a negative history that there is no history of rheumatic, no history of syncope, no history of palpitation, no history of chest pain, no history of dyspnea on exertion to rule out embolic stroke. As in patient of embolic stroke because of rheumatic heart disease or because of atrial fibrillation, the patient may have history of syncope, palpitation, chest pain, dyspnea on exertion. Then in a patient of hemorrhagic stroke, usually there is loss of consciousness or there is impairment. There is impairment of consciousness because of increase in intracranial pressure. There will be signs of raised intracranial pressure early in a patient of hemorrhagic stroke. The patient might have vomiting, the patient might have headache, the patient might have seizure, the patient might have loss of consciousness. So these are all the features of hemorrhagic stroke, the signs of raised ICT. The patient might have headache, vomiting, convulsion, everything. But after the onset of weakness, so this is also a differentiating point. Earlier I told you the patient of seizure may mimic stroke. Now I am telling you that patient of stroke may have seizure. Yes, but the onset is important. If the patient is first having weakness followed by seizure, mostly is because of hemorrhagic stroke or it can sometimes be because of thrombotic stroke. But the first complaint was weakness, then stroke.